Dr. Rafich here from Vet Triage. We are continuing on with this issue of JAVMA from October 2016. We are talking about this paper, Overdiagnosis. Now, uh, um, I'm not trying to be mean to this author or to JAVMA for publishing this paper. I think it's absolute garbage. I'd welcome Dr. Brennen, McKenzie anytime we can do like a podcast type interview style video and talk about this paper and see if Dr. McKenzie still feels strongly about it. This is a terrible paper, in my opinion, as it stands currently. And I can't believe JAVMA published this. I've seen papers that are way better than this get rejected, and the fact that this became published, I don't even know. But let's go through it, and I'll offer some rebuttals, some thoughts to why I disagree with a lot of these points. And again, if Dr. McKenzie ever wants to chat, I'm happy to. And if I'm incorrect, then I'm happy to admit that as well. I'm sure a lot of work went into it. It's got 56 references to it, but boy. Anyway, misdiagnosis is defined as incorrectly identifying a patient's disease or diagnosing a disease the patient does not have, and a missed diagnosis is failing to detect a disease that is present in a patient. Overdiagnosis refers to the correct identification of a disease that is actually present, but that will never cause clinical signs or clinical harm, like death, in which subsequent testing and treatment on balance causes patients more harm than good. So here's my first rebuttal. We have cases, for example, of adrenal gland tumors in dogs. We call them incidental nomas. Incidental, the key word in the key part of that word, because we recognize that although we diagnose an adrenal gland growth or a tumor, that it is incidental because the patient is not exhibiting any clinical signs. Now, it could also be that it is an actual tumor. Maybe you're catching it early on, or maybe it's smaller than you'd recognize it to be, or maybe it's not invading any structures yet, and so it may be actually malignant, but you caught it at the time where it doesn't appear so on your diagnostic testing. So, in that scenario, I think most veterinarians would even consider an incidental noma a disease, whereas here they define overdiagnosis as identifying a disease in a patient. If you're going to call it a disease, then it's presumed that that is actually a pathologic condition. Now, an incidental noma, for those dogs that have incidental adrenal gland tumors, that's not normal either. It's normal to not have anything wrong with your adrenal glands. And so if you want to have another word that describes it, instead of calling it disease or pathology, go for it. We usually call it incidental findings. And so that's right off the bat within the definition of overdiagnosis. I'm not sure I agree if you're going to use the word disease. Now, if you're going to say in here identification of an incidental finding or something like that, then I can probably get on board with that. Moving on, the diagnosis is technically correct, but such diagnosis leads to no benefit for patients. The problem of overtreatment is often connected to the issue of overdiagnosis. Overtreatment is the application of therapeutic interventions that provide no net benefit or do more harm than good for patients. So this will be a common theme in my rebuttal to this paper, is that you're right if you were to treat a patient for a condition that they don't actually have, or for example, let's say you go in surgically to remove that adrenal gland tumor and the animal dies from anesthesia and surgery, and the tumor comes back benign, it never would have caused disease in that patient, then sure. But before that patient gets taken to surgery or any treatment is implemented in a patient with an incidental finding, there's discussion with the pet owner or in human medicine with the patient about pros and cons of that treatment. That's the point of clear communication. So if you go over the pros and cons of a treatment for an incidental finding, an overdiagnosis, and the patient or client says, I'm willing to take the risk, then you go for it. Or you can interject your own opinion as a physician and say, look, we found this thing. In my opinion, based on your patient history, everything I know about you or your animal doesn't really warrant the treatment. There's too many negatives. but the choice is yours. Fine. Okay, how much of a problem is overdiagnosis? It's a common and serious issue in human medicine. It causes substantial harm in terms of costs, wasted resources, and patient and caregiving suffering. In human medicine, screening programs intended to detect cancer in asymptomatic individuals provide a useful illustration of this problem. For example, using prostate-specific antigen, or PSA, as a screening test for prostate cancer in asymptomatic men has been associated with an overdiagnosis rate of 5% to 75%, depending on the population evaluated, with the best estimates suggesting that among men in whom prostate cancer is diagnosed on the basis of the screening, 25% would be expected to have never experienced clinical illness or die because of prostate cancer. That means that 75% of those men would have had issues had you not acted on that screening tool. So even though there may be a quarter of folks that had treatment that harmed them and the disease that was diagnosed wasn't actually going to progress, 3/4 would have suffered had the doctor not acted. Also, when you see a range of 5 to 75%, which is basically 0 to 100%, then there's something wrong. There's something wrong with the actual studies that are doing this. There's flaws there. And so I don't agree that screening tests automatically make a physician jump to aggressive treatment. I think that because prostate cancer is so common in men as they get older, and the detriment to that disease progressing is huge, screening is still worth it. And they give another example here in the case of mammography to screen women with breast cancer. The risk of overdiagnosis varies with the age of women screened and other factors. The best estimates suggest about 30% of breast cancers detected through mammography screening are overdiagnoses, which means 70% are not. But estimates range from less than 10% to 90% depending on the population tested. It's the same thing. It's basically 0 to 100%. So which means that there's something wrong with the studies there. And I know women who have had a very early age bilateral radical mastectomies with chemo, with radiation at the age of like 25, because they had all the tests performed, not just a screening tool, but multiple diagnostics that show that there's enough risk here, plus familial history of risk in that person's medical history, and they're cured afterwards. But they went through years of torture, right? Surgery, radiation, chemo. Had they not done that, though, they would have hit the age of 40 and then had metastasis or something. So it's just so bad. How is overdiagnosis identified? One challenge in identifying it can be in individuals is it can only be done in retrospection, after any opportunity for making a diagnostic or treatment decision has already passed. If, for example, prostate cancer is diagnosed in an asymptomatic man, this diagnosis can only be clearly classified as an overdiagnosis if the condition is left untreated and never results in clinical signs or death. Individual patients and veterinary clients sometimes elect not to pursue treatment, and when the identified conditions they choose not to treat regress spontaneously or fail to produce clinical signs, we classify that as overdiagnosis. I would say you classify that as incidental findings. However, although such outcomes provide evidence for the existence of overdiagnosis, they are not very useful in guiding diagnostic and treatment recommendations for individual patients at the time of initial diagnosis. Overdiagnosis is frequently detected through evaluation of epidemiological data on disease occurrence and outcome. If an increase in the number of cases of that disease is accompanied by an increase in the number of deaths caused by it, then there may be true increase in disease incidence. However, if the number of cases of the disease increases but the number of deaths caused by the disease remains unchanged, then it may be overdiagnosis because newly identified cases are not leading to death. So in these statements, they're using death as the only poor outcome, let's say, or any outcome at all, well, poor outcome of overdiagnosis. But there's a range, a spectrum, if you will, of things that can happen to a patient, not just death, that meant that that disease was actually real. The other example that I have to combat this is rabies. Rabies is 100% lethal. I think, and I'm not up to date on literature on this, but I think there's only been one girl in human history that we know of in the literature that survived rabies infection. Meaning they didn't get prophylactic treatment, they didn't get the post-exposure of rabies vaccines, they got bit by a rabid animal and then survived it, which is like 0% chance. So one person in, as far as we know in human history, or at least in the medical literature. So if you get bit by an animal and you don't show signs of rabies yet, but the animal is rabid, then would this person recommend the prophylactic rabies vaccinations? Vaccines are not completely safe either. There's always risks of vaccinations. COVID-19 is a good example of that, but any vaccine before COVID carries with it risks. That's why the whole autism concern came about, that maybe the products in the vaccine are causing issues affecting children or whatever. Just one example of many, 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 many. So it's the point is that sometimes the disease itself is so scary that if you don't act now, if that disease comes to fruition, then it's too late. Versus if you implement now, maybe the treatment will have side effects, but had the disease occurred, the effects of the disease would have been way worse than the side effects of treatment. It all comes down to client communication. That's it. I mean, this is not a hard problem to solve. What is the harm of overdiagnosis? It can cause waste and misallocation of medical resources. It can also increase morbidity and mortality and have a deleterious psychological impact. It is estimated, for example, that overdiagnosis and overtreatment of clinically irrelevant lesions detected through mammography costs $4 billion annually in the U.S. Another study suggests that the treatment of people in the United States with mild hypertension that does not result in any benefit in terms of reducing symptoms or early death may cost $32 billion annually. I mean, that's because breast cancer and cardiovascular disease are the most common things we see. And if you don't treat them early on, after you've adequately communicated with the patient the pros and cons of treatment and what can happen if they treat and don't treat, then it's so crazy. And I want to know how many physicians are treating mild hypertension. Something as simple as white coat syndrome, right? Where the patient, human or animal, goes into a hospital, blood pressure goes up because they're nervous just being there. What doctor wouldn't double check that blood pressure again in the hospital and then again at home to make sure that hypertension is real? Or provide other cardiovascular tests to make sure there's actually heart disease there. It's crazy, man. This paper is difficult. For example, even though there is now widespread awareness that a high proportion of prostate cancer diagnoses are overdiagnosis, most men with positive screening test results are still subject to additional testing. That you're supposed to do that. That's the point of screening. In one review, 85.9% of men with positive screening for prostate cancer had at least one biopsy procedure, and treatment of prostate cancer can have substantial adverse effects. 50% of men who have undergone surgery because of prostate cancer experience sexual dysfunction, 30% difficulty urinating, 0.1% to 0.2% will die. That's why you talk to them about pros and cons. You don't have to go all the way to biopsy. You can retest them later on. You can provide three-dimensional imaging with like CT or MRI. You can do other things and not just go right to treatment. And then also, I want to know what the medical boards would do. So let's say you said, oh, this is an overdiagnosis situation, right? I diagnosed this man with prostate cancer based on a screening tool. I'm not going to do anything further because I believe that overdiagnosis is a problem and this man he's young and has no history of it or whatever. And then that guy gets cancer. 10 years, 20 years later, is the medical board going to protect you for overdiagnosing, for being a good doctor and not risking overdiagnosing, or are they going to chase you? They're going to freaking chase you, man. And that's the same for veterinary. You see a herniated disc in a dog, incidentally, on radiographs or MRI or whatever, and you don't treat it, and then the dog becomes paralyzed a year or two later, and then it's found out that disc herniated 2 years later. You think a medical board isn't going to chase you for that if the client reports you? You're out of your mind. Given that many asymptomatic men in whom prostate cancer is diagnosed on the basis of screening, likely about 25%, but as much as 75%, will never develop clinical signs or die, If left untreated, the risk of treatment may well exceed the benefits in this population. Potential psychological harm can occur. Quality of life diminishes after diagnosis of cancer is made. The risk of suicide and cardiovascular death increases even before treatment is started. And that's why you have to communicate effectively with the patient or the client. What causes overdiagnosis? Screening tests increase sensitivity of diagnostic tests, use of screening tests in inappropriate populations. That I would agree with. We used to, and again, this is outside my expertise, but in cats, we used to test a lot more for FELV, FIV in cats, and in kittens rather, and I think that folks have stopped doing that unless it's the appropriate population, because we were euthanizing animals, kittens and cats, just based on a positive test because they were suitable for adoption. But that's not what overdiagnosis is, though. That's a well-known phenomenon where when you decide on using a test based on sensitivity and specificity, you decide, is the disease that you're screening for so scary that you should cull animals if a positive test results comes up from the screening tool or not, right? You have to weigh that pros and cons. And so, that was the idea there, that this disease is so egregious that even if we have a false positive, it's worth euthanizing that animal, because if it's truly a positive, or the test did not diagnose the patient, it was a false negative, then it could spread that disease faster than you can redetect the actual disease. So, the training of physicians and veterinarians includes an emphasis on systematic methods to prevent misdiagnosis, especially to reduce the risk of failing to diagnose uncommon diseases and diseases that might be present in an atypical manner. Doctors may also be prone to overdiagnosis because they are likely to be punished in the form of blame or litigation in failing to diagnose medical conditions, whereas there are almost never any negative consequences for unnecessary diagnosing or treating conditions that would never have caused any harm if undiagnosed. 98% of people given an incorrect diagnosis of cancer on the basis of screening were still glad they had the treatment, even though they did not actually have cancer later on. Overdiagnosis in the veterinary context. The economic model of vet medicine is different from human medicine and may reduce the risk of overdiagnosis. Clients have to pay for testing and treatment, and this may restrain the indiscriminate use of diagnostic tests and treatment. Unlike physicians, veterinarians must face the problem of economic euthanasia, which can lead to the death of patients with treatable conditions when resources for care are limited. Overdiagnosis can lead to owners euthanizing if they are emotionally or financially unable to cope with the diagnosis, even if the condition ultimately may not have caused any clinical consequence. Again, it's all about client communication. If you have a normal animal and you diagnose a bad condition, and the owner's like, oh my God, I can't handle it, I have to euthanize this animal. No veterinarian would do that. You shouldn't. The veterinarian would say, no, I'm just letting you know there's a risk of this, but there's no symptoms. Don't choose a decision that's irreversible. Euthanasia is a one-way street just because of this test. We should just be aware of it and monitor it. Here's the symptoms you look out for if this disease comes to manifestation. Christ, man. An example of a practice that might lead to overdiagnosis is pre-anesthetic blood testing of healthy patients. The intent is to detect subclinical conditions that might influence the risk of anesthesia and surgery, and there is evidence such testing frequently uncovers abnormalities. Perhaps such testing reduces overall perioperative morbidity and mortality rates by detecting occult disease that would raise anesthetic or surgical risk, or perhaps it leads to detection and benefit treatment of such disease unrelated to the immediate surgical issue. However, pre-anesthetic testing of overtly healthy veterinary patients may also lead to detection and subsequent investigation or treatment of diseases that would never have caused harm. And such testing might cause harm by discouraging beneficial surgical interventions if owners or veterinarians elect not to proceed with these interventions owing to clinical laboratory abnormalities that may not have actually impacted the risk of the procedure or well-being of the patient. In the worst case, clients may elect euthanasia based on the screening test. Oh my God. Here's another example. So you have a patient, it's about to undergo dental, it's a 3-year-old lab, and you find on pre-anesthetic blood work an elevated liver enzyme. Vet students and new graduates struggle with this all the time. Here's the answer. You call the client before you perform anesthesia. You say, we found a high liver value. Well, my dog's been healthy. There's been no symptoms. Agreed. Understood. There's maybe a spurious increase, maybe lab error. Maybe this animal just runs elevated, or maybe it's the beginning of something serious. We don't know. Here are your options. We either discontinue the procedure, retest the lab work in about a month, because we know that the half-life of such liver values are about 3 to 4 weeks. And then if it decreases or it's normal by then, we then proceed. Or second option, we go forward with the anesthesia and surgery, understanding there could be risks associated with it now that are increased because anesthesia goes through the liver. Or you can go all out and have an ultrasound of the abdomen done, look at the liver, and then consider either at that time or later on a fine needle aspirate of the liver, or even a biopsy of the liver, or you can do nothing. It's up to you. We found it early. It may mean nothing. It may mean everything. We don't know. That's the discussion you have. How can overdiagnosis be prevented? Research is needed to identify the extent of overdiagnosis in the veterinary context. And then he does go through a bunch of possible research projects. I'm not going to go through that. Client communication is how you prevent it. That's how you prevent it. Client communication. Pros and cons. The authors of one review of overdiagnosis in human medicine suggest that investigation and screening should be selective and targeted. Unexpected abnormal findings should be considered within the context of a full clinical picture, and in most cases repeated or otherwise verified before a diagnosis is made or before treatment is considered. Applying such a strategy in veterinary medicine might be prudent even without a quantitative understanding of the extent of overdiagnosis in the field. This one paragraph should be the entire paper. That's it. That's literally it in like a sentence. That's what it should be. So sorry, JAVMA, and to Dr. McKenzie, I don't like this paper. I think it's dumb, and it's made up, unfortunately. But I'm happy to talk about it if Doc wants to. Otherwise, folks can leave comments and let me know what you think about it, and go from there. See you tomorrow. Bye-bye.